Welcome to a new episode of Medicine in 3 minutes. As usual, we go straight to the point. The subject is bravely made clear and often illustrated. Let's start. Today's topic is about pituitary tumors. During this presentation, we will follow the next plan. Classification of pituitary adenoma, secreting adenoma, non-secreting adenoma, silent adenoma, aggressive adenoma, microadenoma, macroadenoma, clinical features, endocrine effect, hyperprolactinoma, Cushing disease, growth hormone, gigantism versus acromegaly, associated MEN1 syndrome, diabetes insipidus, pituitary apoplexia, panhypopituitarism, subarachnoid hemorrhage. We can classify tumor into secreting, non-secreting, silent, and aggressive tumor. Let's start with secreting tumor. Among secreting tumors, there are 4 categories. The first one is prolactin secreting tumor. The second one is somatotropic tumor. The third one is corticotropic tumor. And the fourth one is stereotropic tumor. Prolactin secreting tumor occur in 60% of cases. There is a predominance female with 10 female to 1 male. And they must occur at the age of 32. The second category is somatotropic tumor. Somatotropic are around 13%, and they occur at the age of 47. The third one is corticotropic tumor. It's around 6%, and most of them are microadenoma. The last one are stereotropic tumor, which are 1%, and most of the time they are hyperthyroid. Tumor secreting prolactin is the first one, 60%. Maximum occur at the age of 32, 10 female versus 1 male. The second one is tumor coming from growth hormone, 13%. They occur at the age of 47. The third one is ACTH tumor, which are microadenoma, 6%, and the last one is TSH tumor, hyperproduction of thyroid, 1%. Non-secreting tumor or no functional adenoma, they represent actually 30% of pituitary adenoma. The term non-functional should be preferred since in about a third of cases there is hormonal expression without clinical translation, but which can serve as biological marker. Most of these tumors are gonadotropic adenoma. Silent adenoma, they are less frequent. Tumor compress chiasma. They secrete an inactive prohormone, explaining the absence of clinical sign. The hypersecretion of ACTH without hypercorticism. Silent tumor, compression of chiasma. The last category is aggressive or atypical adenoma. and carcinoma. Most often, metastases occur 5 to 16 years after the clinical onset. Dissemination to nervous system through cerebrospinal fluid, lung, bone, liver, or even lymph node. Primary adenoma from anterior pituitary, third to fourth decade of life, between 13 to 40. Male equal female. Incidence in autopsy study approximately 20% in autopsy. They are classified as microadenoma, less than 1 centimeter, or macroadenoma over 1 centimeter. There is functionally secretin and no secretin. Clinical features include mass effect, intracranial hypertension, bitemporal hemianopsia by compression of chiasma, and nerve compression. Think about internal carotid artery in cavernous sinus. There is the third, the fourth, V1 and V2. Bitemporal hemianopsia by compression of the chiasma. And the fourth, there is a deviation of the A. Then we move to endocrine effects. Prolactinoma with infertility, amenorrhea, galactorrhea, and decreased libido. ACTH production with Cushing disease, growth hormone production with acromegaly and gigantism, and panhypopituitarism, hypothyroidism, hypoadrenalism, and hypogonadism. Let's start with pituitary hyperprolactinemia. There is excess of prolactin. Women with amenorrhea and galactorrhea, men with hypogonadism, and there is bitemporal hemianopsia. Most common cause is functional adenoma. Other etiology include nursing, stress, stimulation, and drug like haloperidol, reserpine, H2 blocker, and hypothyroidism. Growth hormone and gonadotropin lost early and ACTH lost last. Prolactin, think of the anterior pituitary. On the other hand, oxytocin, think about posterior pituitary. Prolactin is about the production of milk. Oxytocin is for the secretion of milk. Most common lesion of pituitary is adenoma. Women, amenorrhea, galactorrhea, and for men, erectile function drop. Women are juicy and men are dry. Workup, exclude drug and hypothyroidism, exclude pregnancy, check prolactin level, MRI, treatment, dopamine agonist, bromocriptine, cabergoline, surgery, radiation as last resort. Cushing, think about GFR. G for glomerula, think salt. F for fascicula, sugar. R for reticula, androgen. and the medulla is epinephrine, fight and flight. Regarding Cushing, we ask the question, is it Cushing syndrome? To answer this question, we give 1 milligram dexamethasone test at 12 a.m. at night, and we measure cortisol and ACTH blood test at 8 a.m. If cortisol is over 5 grams deciliter, we say it's Cushing. Under 5 grams, it's normal. Where is the lesion? Is it in the pituitary, in the lung, or adrenal? To answer this question, we give a dexamethasone 8 milligram at 12 a.m. and we measure cortisol and ACTH the next morning at 8 a.m. If ACTH high and cortisol low, it's pituitary. If ACTH high and cortisol high, it's lung. If ACTH low and cortisol high, it's adrenal. Pituitary acromegaly and gigantism. Acromegaly, gigantism. Acromegaly, think about excess of growth hormone. To differentiate gigantism and acromegaly, before epiphyse solidification, before the 20 to 22, it's gigantism. After this, it's acromegaly. Most of the time, it's macroadenoma in 75%. Clinically, enlargement of hand, feet, tongue, and mandibula. CHF, carpal tunnel syndrome, most of the time bilateral, diabetes, and hemianopia. Acromegaly is a chronic disease. It takes 9 to 10 years before diagnosis is considered. How to make diagnosis? IGF-1 somatomedin, glucose load, and MRI. How we treat? Octreotide, dopamine agonist, radiotherapy, and surgery. Transsphenoidal approach, endoscopic endonasal surgery. Then associated MEN1 syndrome, diabetes insipidus, pituitary apoplexy, and subarachnoid hemorrhage. MEN1, pituitary adenoma, parathyroid hyperplasia, and pancreas tumor. Diabetes insipidus, posterior pituitary gland, secretion of vasopressin, antidiuretic hormone ADH. Diabetes insipidus, thirst, tachycardia, hypoglycemia, hypotension, and low blood pressure, and low specific gravity, low osmolarity. Pituitary tumor apoplexia, abrupt onset of headache, visual disturbance, reduced mental status, and panhypopituitarism. Sign and symptom of subarachnoid hemorrhage. Hypopituitarism, primary Addison plus primary hypothyroidism. Hypothyroidism, dry skin, sensitivity to cold, constipation, no lactation, bradycardia, loss of hair, goiter, irregular bleeding, and depression, diabetes insipidus. Primary Addison, asthenia, anorexia, hypotension, hypoglycemia, digestive disturbance, and depression. In hypopituitarism, there is no melanodermia. Subarachnoid hemorrhage, spontaneous cerebral artery aneurysm, severe headache, thunderclap, worst headache of my life, followed by neck stiffness, meningeal irritation, photophobia, nausea, and vomiting. Seizure, transient diplopia, CT, bleeding intracranial, cisterna texacosta, treatment, admission, nimodipine to reduce vasospasm. Most pituitary adenoma arise from the pituitary gland extending through the diaphragm cella up to optic chiasma. Most of craniopharyngioma arise from the supracellular region extending up to the third ventricle with lobulation and down to the intracellular region. Most of Radcliffe cysts arise from the pituitary fossa, have small volume due to the relatively small extent. This is about the differential. Craniopharyngioma, slow-growing brain tumor, more common in children and elderly. Standard growth, if large tumor, vision problem, increased urination, thirst. Who's to blame for recurrence after surgery removal? Thank you for watching this episode of Medicine in 3 minutes. Make sure to put the like button and subscribe. Your comments are very welcome. Thank you.